I don't have anything to disclose. There are no financial relationships either to the content or the person for presenting. And then today's topic is trauma disorders and trauma treatment approaches. And this was prepared by Dr. Lindsay, who is Executive Director of Clinical Services and also based at ASAP. And hopefully by the end of the presentation, if you were to absorb, it's a lot of material. So the beauty is you'll get copies of the presentation and you can review it at your own pace. But hopefully you'll be able to see be able to differentiate the difference between stress and trauma when we talk about events. See what are the key characteristics of common trauma reactions, typical course of trauma, and signs and symptoms. And then see how do we apply trauma treatments and what are recommendations in terms of trauma exposure. And then finally, how would you put or add this to your daily practice? If anything today, just being aware that trauma is extremely connected or very strongly connected to substance use, not all substance use, but a large amount, especially in the state of New Mexico. And so something that we really want to consider when we're treating patients and how to address it and what to do. So one of the first things is to recognize that there's a difference between stress itself and trauma. That on a daily basis, we're faced with different types of stress in terms of intensity, in terms of amount, frequency, et cetera. And that is very different as when we are presented with a traumatic event, right? And so stress is part of our daily lives. We want stress to be part of our daily lives. We never talk about getting rid of stress, but we talk about managing stress, right? So that if we didn't have stress in our lives, if it was so low or almost non-existent, we would have no motivation to even be here today, no motivation to go to school, to pay rent, et cetera, right? So there is a need for us to have some stress and manage it. As a matter of fact, optimum stress is a little bit high for us to feel motivated to do something, right? Including keeping ourselves alive. The danger is when we're in that optimum stress and we reach the top and stay at that level and do not reduce it or manage it throughout the day so that it kind of goes up and down. If we remain at the top, then as you notice, this is a bell curve. It tips to the other side. It might look like optimal stress, but at that point, it actually has become exhaustion. And so we'll have various symptoms that we experience, right? Depending on what kind of stressors we are facing. If we remain long enough in exhaustion, we'll eventually go right into burnout. And if you remember, one of the characteristics of a bell curve is that if you cut it in half, they seem to mirror each other. So once you are on burnout, on pure burnout, you are not motivated to do anything just the same way that you're not motivated when you have no stressors. And so very important to know this, because sometimes our patients have a misunderstanding of wanting to get rid of stress. And it's really how we manage it. What kind of resources do we use, right? And so if we teach our patients, and very often if we know how to practice it, we can teach it even better. This thing called resiliency, right? How to be able to handle and manage stress so that they can function in a better way, right? Substances can help people get some functionality, but that's not very long-term. And then it also affects so many parts of their body that eventually it starts working against them, right? So maybe smoking is one way to manage stress, but then eventually now you're having chronic lung issues, and then eventually you develop something even more grave, like cancer, lung cancer, et cetera. So it's not a good way to manage stress, but definitely is a way. So our job as providers, as peers, as social workers is to be able to educate our patients and provide to them what are healthy alternatives. So notice that response to stress can vary, right? Depending on what kind of stressor we're facing, right? So many of you who are here have done a lot of schooling, and so that how much you prepare for exams versus when you don't is something that not only does it happen in intensity, right? So but it also changes, right, over time, and we're used to it, right? At some point we get used to it, as opposed to, for example, we leave our job and then there's an accident. That would be something that's a stressor that is not a typical stressor. So that's going to be very important. Individual history is very important. I think very often as parents, we really want our kiddos never to go through tough things. And actually we do a disservice, right? So if we can be supportive and teach them how to manage stressors, they will have very strong resiliency. So when big stressors present, they're able to manage them so much better. Coping style is another one, right? So like I said, somebody might use smoking as a way to cope versus somebody who goes running and or goes hiking. And so that's going to matter. And then availability, right? So let's say exercise is something that helps me cope with stress, but I don't have any place to go exercise. Where I live, it's a dangerous area. So those are, there's no availability of external ways to manage my stress. And then internal would be, let's say if I struggle with depression or if I struggle with anxiety, I don't have the tools to know how do I do that. And then my anxiety and my depression is probably increasing my mismanagement of stress. In general, we have an innate ability to adapt and cope to stress. Actually, we're meant to have it, right? If we are stressed at that yellow level, at that optimal level, then we are really interested in surviving, right? So we definitely want to do that. If we think of the homeostasis model, where our body always wants to go to that same state, then our body is always trying to recuperate. The problem is when we don't give it a rest, when there is not a period of us to reduce it, to engage in resiliency, then stress can become something lethal. So we definitely want to be able to provide, like I said, our patients with tools, and nothing like us practicing with different tools that are healthy so that we can even, when we're talking with our patients, we're understanding even some of the barriers, right? And then again, understanding that there's a difference between managing stress that is acute versus stress that is chronic. So if it's something that's just temporary, as we thought, even about COVID, right? We thought it was just going to change very shortly. We kept saying after 2 weeks, things will go back to normality. We kept thinking that it was more of an acute stressor, and eventually we realized it's been and still is something more chronic. So in those cases, then we want to engage in something a little bit different, right? So like medication, psychotherapy, lifestyle changes, etc., in order to be able to address it. The DSM tells us, so that's stress. So on the other hand, we have trauma, and the DSM defines trauma as an actual or threatened death, serious injury, or sexual violation resulting in one of the following from one of the following scenarios. This is the definition of trauma for PTSD. In the field of trauma treatment, sometimes we talk about big T and small t, big trauma, small trauma. That can be a little bit confusing because small t makes it sound like things that are small trauma are not as traumatic. They are just as traumatic. It's just they're not something that makes an individual meet criteria for PTSD. So what's really important is understanding, right? For big traumatic events, generally we feel that our life is being threatened or something. It's happening where there's an injury, like sex violations, etc., where we feel like, again, our life or someone else's life is in major danger. For PTSD, you'll notice that the definition includes even what type of traumatic event. Is it one where it happened to me? Is it one where I witnessed that the event happened to someone else? Is it learning about violent, actual threatened death of a close family member? And this does not include like playing games, video games that are very violent. Does not include watching movies that are very, very violent. An example would be if I'm hearing about a loved one and they took their life, and I hear about the details and I see pictures, that would be an example, right? It does apply for people who work, for example, in the police force or firemen who see some pretty gruesome scenes. And then notice experience repeated or extreme exposure to aversive details, right? But again, not just from games, etc. So that's where the police and the firemen would apply. An interesting way to differentiate between stress and trauma, which I really like, is thinking traumatic events are stressful events, but stressful events don't necessarily are traumatic events. A good example of a stressful event that would not qualify as a traumatic event, say for PTSD or any of the other trauma disorders, would be if, say, for example, CYFD has opened a case and they're taking my kids away. That feels pretty stressful. I could even say very traumatic, but it's not traumatic at the level of PTSD. Now, when we talk to patients, we would never say that is not traumatic enough or that's not stressful enough. One of the important things about resiliency is being able to validate how difficult a situation is, right? So types of trauma, you have shock and strain. And then here's another very important factor. If the trauma or traumatic events are happening during childhood or adulthood. And this can be very detrimental. During childhood, our brains are changing. They're developing, right? We're going through all this neurodevelopment. And so often when kiddos experience trauma and experience repeated trauma, their development either it's not linear. So it's kind of like it skips places. And then it could be that there are certain aspects of that development that never get developed, right? And so it's interesting to understand, right? So we might have kiddos who experience traumatic events, and they have a really poor sense of reality, right? Like as to who do they trust? What is the world about, right? They have ideas of the world always being bad versus an adult. Now, that doesn't mean that it's less, it's just the effects are very different. And that's important to note because when we're treating our patients and learn that they experience trauma as kids, they're going to be struggling with certain aspects that are much different than somebody experiencing trauma as an adult. So if you, again, I like this pyramid, it reminds us of the adverse childhood experiences because there's nothing like things happening right when your brain is developing and it doesn't get to develop the way that it should. Responses to trauma, it can vary, right? Depending on the type of trauma, how close you were, did it happen to you or others? Previous trauma, it's interesting to see how people can be resilient up to a certain point sometimes. And then there is a traumatic event that kind of just puts them over now into a PTSD or trauma, another trauma disorder. Coping skills, response support system, life stressors, right? Other things that are happening, perception of the event, right? How much did it get distorted? Here are a couple of things that are interesting too. If you take 10 people who experienced traumatic event, so like let's think of a natural disaster where all 10 felt their lives were threatened. Out of the 10, actually 7 are going to go on to not develop PTSD or other traumatic disorders, which is pretty interesting because that's the majority. That means that only about 30%, only 3 out of those 10 are going to go and experience trauma, right? PTSD symptoms or other trauma disorders. What's interesting, people generally ask what's different. Very often people that are working on PTSD will ask, am I broken? Is there something wrong with me? What happens very often is at the beginning, if you were to take all 10 and ask them what symptoms they're experiencing, they will all tell you they're experiencing PTSD symptoms. That's why we never, ever diagnose somebody at the 1 month mark, right? Anything prior to that. Because you would ask patients and they would say, yep, I'm having nightmares about the event. By the way, PTSD is one of those diagnoses that gets misdiagnosed very often. So there are a lot of people walking around that do not have a PTSD disorder, that they actually have, they might have traumatic events, but they don't meet full criteria for PTSD. So nightmares need to be related to the traumatic event. So often they'll talk about nightmares, but about other stressors. So that wouldn't qualify as a symptom. But anyways, if you were to ask all 10, what's really interesting, they will tell you that they're experiencing nightmares about the event, that they're avoiding certain things about the event because they feel so anxious, that they're feeling very depressed, very anxious. These are all symptoms for PTSD. What's very key for all of us who are in this room is when we're talking to those patients is to start, first of all, validating, right? That they went through something really horrible. Often those 3 out of the 10 hear from their really close people. They hear things like, oh, come on. It's not like this doesn't happen to anybody else. Just get over it. It wasn't that bad. And so we'll hear sometimes from our patients something like that, where they say, this happened to me, but then I know that there are more horrible things that happen to other people. And so this is an opportunity for us to be able to say, that's true, but then what happened to you was pretty bad. And I can totally understand what you're experiencing. So validating, normalizing that it is part of PTSD, and then avoidance would be the other one, right? So those 3 are continuing to avoid a lot. People, places, events that remind them of the trauma, versus the other 7 are starting to be able to face some of the stuff that they experience, some of the places, thoughts, etc. And so that helps them to be able to move on, so to speak. So it isn't that those 3 are broken. It is just lacking resources. They might have other things, comorbidities, right? So maybe they're already struggling with depression, already struggling with anxiety, personality disorders. We're just gonna show you a quick graph about that. And so what we want to do is be able to look into this post-traumatic growth, right? So people can recover. If we have 10 and 7 recover, there is such a thing as resiliency, right? And so we talk about short-term and long-term. Again, we talk about the 3%. And they will tell you that their symptoms feel almost as if it just happened yesterday, even though it's been years. If you look at the neurological effects, it's like these individuals, it's not like their alarm system is activated or not, is that their alarm system is on full blast. So imagine being in a house where the alarm system is on full blast, and somebody's trying to tell you something and you're trying to hear, but the alarm system is going on so loud. That's what happens with somebody who has PTSD, right? And so they feel tired, everything, their attention is everywhere. They're hyper aroused because they're constantly looking everywhere. So does it make sense that some of the patients would self-medicate with opiates? Of course, so that they can sleep, so that they can feel like at least they can have a moment, right? So what our job is just finding alternatives. So often in treatment, what we do is lower the volume of that, right? So here are some of the other disorders that I mentioned. This is for PTSD. Notice that there are other ones other than PTSD, like acute stress disorder. And there is comorbidity with other disorders, right? So this is a graph that I was telling you. There's a lot that can be shared between PTSD and other disorders, including substance use disorders, right? So again, it makes a lot of sense in terms of why people would find ways. Why would they be so desperate to just get one night of good sleep and just use something that would be calming, like an opiate? What often happens is they might use an opiate to calm down, and then they notice they just cannot get out of it, and they might end up using some type of stimulant to get out of it, and then again, and just go back and forth. So now we have somebody who's doing polysubstance. In terms of treatment, CBT approaches are very important. It's good to kind of talk to our patients. What skills can they put in? PTSD treatment can be tough. And so nothing like having skills to be able to know how to do self-soothing, how to do positive self-talk. Often you'll hear me or hear us in the group talk about seeking safety. Great approach. It talks about both substance use and PTSD and how does that work. And then you have things like exposure therapy, where the patient talks about the event within a safe place, within a certain amount of time. Cognitive therapies, where you're looking at distortions. I think what happens is things get distorted. I don't know that they're necessarily erroneous, but they're very distorted, right? Everybody's unsafe. The world is not a good place. You trust nobody, or you trust everybody, which you will see it in PTSD. Notice that here are some specific treatments for PTSD. And if you can think of an umbrella, when you think of PTSD, inside the umbrella is MDD, major depressive disorder, and anxiety disorders. Sometimes people might venture in trying to figure out if that major depressive disorder, it's an added. So if the person has PTSD, MDD, and anxiety, GAD, generalized anxiety disorder, the reality is, my recommendation is you treat the PTSD and you're going to start to see the other two come down. If they don't, then most likely they have had MDD and GAD, right? So prolonged exposure and CPT are the gold standard for treatment of PTSD. Can it happen as you're treating somebody? Let's say you're providing medication and treating the substance use, and can they be doing CPT or PE, prolonged exposure cognitive processing therapy? Yes, most definitely. And they can be very successful. Only times that this might be contraindicated would be if somebody is using a lot, right? So I've had a couple of patients who were using fentanyl or other opiates pretty heavily. So then they're not really present as they're doing the treatment. So in that case, then discontinuing the PTSD treatment, ensuring that we get to a good point, a good place in harm reduction with them will be much better, so that you can eventually do the PTSD treatment. So this is just a little scratch of the surface, as I think they say in English, about PTSD, how essential it is for you to consider it as you're doing treatment. Very often our patients might not feel very safe sharing with us, but that may be an underlying factor in terms of the heavy use of whatever substances. One last thing, I promise. One of the things that I've noticed in working with adolescents, not only do I see use of opiates, but I also see a use of many substances. So I have seen kiddos or adolescents that are coming in with LSD, meth. There isn't a specific drug of choice, so to speak. They're using everything almost like in a desperate mode of stopping the effects of the PTSD. So, and that's it. That's my presentation.